Hey there everyone, my name is Andrew Shedd with Sonoed, and I have another ultrasound lecture for you today. Today we're going to be talking about the gallbladder. The first thing we're going to talk about is how to find the gallbladder, which can sometimes be one of the most challenging aspects of doing this study. Then we're going to review normal characteristics of the gallbladder, talk about pathologies of the gallbladder, some other benign findings that you might see, and then common errors and pitfalls. Now, we all know that the gallbladder lives adjacent to the liver in the right upper quadrant, so finding the gallbladder in our minds is not always challenging, but sometimes finding it with the ultrasound machine certainly can be. The main thing you're going to want to focus on is not only identifying the gallbladder, but confirming that what you're looking at is the gallbladder by confirming its relationship to the portal triad. The portal triad consists of the portal vein seen here in blue or purple, the hepatic artery seen in red, and the common bile duct seen in green. And it's that relationship wherein the gallbladder points towards this triad that is going to confirm and help identify it on ultrasound. The other structure you'll often see on ultrasound is called the main lobar fissure, and this is a fissure in the liver that appears hyperechoic on ultrasound and connects the gallbladder to the portal triad. Now, in some patients this will be more prominent than in others, but it is a helpful finding if you can find it on ultrasound. I'm going to play a couple videos now about finding the gallbladder with ultrasound. There are several different approaches. Remember that this is a three-dimensional structure in a three-dimensional body, so you can find it from many different angles. But these are a couple common approaches, so I'm going to let this video play, and then I'll provide some comments. In the subcostal approach to finding the gallbladder, place the ultrasound probe beneath the inferior aspect of the ribs and scan lateral to medial and back, looking for the gallbladder in this region. Now, this technique can be very successful and easy to learn because you don't have to navigate the ribs and their rib shadows. However, this technique does lend itself towards a lot of bowel gas artifact, and things that I find helpful to help mitigate that are having the patient lean to their left or perhaps sit up a bit. Both of those techniques will help displace some of the bowel gas away from the gallbladder. Secondarily, you can also have the patient take a breath and hold it, and that will help move the gallbladder more inferior. However, if the gallbladder is very painful and tender, this can also be uncomfortable for the patient. I'm going to play a second video now about another technique to find the gallbladder, and then I'll provide some additional feedback. In the X-7 approach to finding the gallbladder, the X stands for xiphoid process, and 7 stands for 7 centimeters to the right. And in this region, you're going to place your ultrasound probe, and you should find the gallbladder in this general region. If you don't find it there, continue over laterally, and often it helps to orient your probe parallel to the intercostal space, and look for the gallbladder in that general region. This technique is the one I use most frequently. However, it does take a little bit more finesse because you have to navigate the ribs and the artifact that they'll create on the screen. Once you find a fluid-filled structure in the right upper quadrant that looks like it's the gallbladder, you'll want to confirm it's the gallbladder, and you'll notice it is a pear-shaped structure. It does have the associated MLF that we talked about, and the most important thing I find is that it points towards the portal triad, and it does so such that it looks like an exclamation point. And that's the most important thing I find when I teach residents to help confirm that it's the gallbladder, is to find its relationship to the portal triad. This also helps you identify the common bile duct, which we're going to measure at a later point. Here's a still shot example of a normal gallbladder. You'll see it's an anechoic fluid-filled structure adjacent to the liver, and it points towards the portal vein and the common bile duct. You'll see that in this image we don't see the hepatic artery, and I find that that's not often seen when evaluating the portal triad. The hepatic artery has a much more circuitous path in the right upper quadrant, and when you're finding the common bile duct and the portal vein in their long axis, often the hepatic artery is not seen in that image. Here's a video of a normal gallbladder in longitudinal axis. You'll see that as the physician scans through it from side to side, you can see it pointing towards the portal triad on the lower left portion of the screen. Now, this is a normal gallbladder in that it has no stones or sludge in it, The wall is not thick and there's no pericholecystic fluid around it. You do, however, see a fold about 2/3 down towards the neck of the gallbladder, but this is just a variant of normal or a congenital finding. Here's a couple examples of the portal triad, both in short and long axis. You'll see that in short axis, the portal vein appears round, and then you can see the CBD and the hepatic artery as well. The hepatic artery, remember, comes off of the celiac trunk of the aorta, and so often you can find those things all in one image depending on the patient's habitus. On the right, in long axis, you'll see that the common bile duct will often be just adjacent to and superficial to the portal vein in long axis, and this is the most common image you'll see when you identify the common bile duct and helps you measure the widest diameter. So just to reiterate, the normal characteristics of the gallbladder are that it has an empty or anechoic lumen, that its anterior wall is less than 3 to 4 millimeters, depending on the author that you read. I'll generally use about 3.5 millimeters as the upper limits of normal. The common bile duct should be less than 6 millimeters, or, depending on other authors, less than 4 millimeters plus 1 millimeter for each decade of life over age 40. And of course, the non-pathologic gallbladder should be non-tender. So here again is that video of the gallbladder in long axis. So those are the things we're looking for. We're looking for stones or sludge in the lumen. We're making sure the wall doesn't appear thick. Looking for fluid around the gallbladder that could be pathologic. And we're making sure that it points towards the portal triad. Then we're going to turn our probe in short axis, and we're going to examine the gallbladder from the fundus all the way down through the neck into the portal triad. And you'll see in this video that you're able to identify all of those structures, and you're also able to see that same fold in the gallbladder as you get down towards the neck of the gallbladder. After I scan through the gallbladder in both long and short axis, I'm going to identify an area of the anterior wall where I can measure it accurately. And this can be done in long or short axis, but the most important thing to remember is that your probe should be oriented perpendicular to the wall of the gallbladder so that you don't have a falsely elevated measurement by measuring the wall obliquely. Here's an example of the anterior wall of the gallbladder. I'll play the video here and you'll see that we'll freeze the image when there's a nice crisp shot of that anterior wall. Then I like to zoom in a bit. And then you'll see the calipers used to measure the wall. The most important thing to remember here is that you measure the wall perpendicular to the wall itself and not perpendicular to the ultrasound probe. You'll see in the lower portion of the image that the measurement is calculated at 2.9 millimeters, which is within normal limits. Now let's go over how to find the common bile duct. This I save for last because it can be the most time-intensive and challenging aspect of the gallbladder ultrasound to learn. I'm going to let this video play and look carefully. You'll see the gallbladder pointing down towards what appears to be the portal vein and the common bile duct. Then we'll add color flow to confirm the portal vein, and you'll see above it that the common bile duct is absent of flow. So that rules out it being the hepatic artery. Then I like to zoom in a bit. We'll freeze the image again, and then we're going to measure the lumen of that common bile duct, and you'll see that it's 1.5 millimeters, which is within normal limits. So what would be some pathologic findings of the gallbladder? Well, principally we're looking for stones or sludge, and then we're going to also look for evidence of cholecystitis or choledocholithiasis. Remember that acute cholecystitis is a very common surgical emergency for the gallbladder. Ultrasound is very sensitive for it and beneficial to the patient in that it spares them radiation or IV contrast of CT scannings. Ultrasound is also readily available. Now remember that the most sensitive test for cholecystitis is the HIDA scan, but this often is not readily available. In regards to cholecystitis, there are several things we're going to be looking for. The overwhelming majority of these cases are associated with stones or sludge in the gallbladder, so that's the first thing you're going to try to identify. The sonographic Murphy sign is the most sensitive finding of cholecystitis, so don't forget to ask the patient if, as you press on their gallbladder, if that is the maximal location of their pain. We'll also want to look for inflammatory changes, so thickening of the anterior wall of the gallbladder or pericholecystic fluid. And lastly, we'll want to see if the common bile duct is dilated, as this would be evidence of choledocholithiasis, or a stone impacted in the duct. Gallstones are going to vary in size. This is a spectrum from sludge to more of a sand-like material to very small stones to sometimes very large stones. These are going to be characterized by an echogenic rim with dense shadow deep to the stone. And unless they're impacted in the neck, they should be mobile and gravity dependent. Now, remember, very small stones may not shadow, and also, if a stone is impacted in the neck of the gallbladder, it can be very easy to miss, so you want to examine this part of the gallbladder carefully. Lastly, if the gallbladder is completely full of stones, it can be very challenging to find and identify because all you'll see is the wall, the echo of the stones, and then very dense shadow. And this is called the wall echo shadow sign and can be a challenge to identify. Here's an example of a lot of small stones. You'll see them at the dependent portion of the gallbladder. They look like little pearls and they have dense shadow behind them. They're lined up in a row. I'm going to let this video play for just a moment. Be sure that you can identify these gallstones. Here's an example now of one very large stone in the gallbladder. You can see that it's about 2 centimeters, maybe a little less, but has very dense shadow behind it. And next, I want to show you an example of that wall echo shadow sign I mentioned. This is the gallbladder in long axis. And if you look here on this still shot before we played the video, you'll see that what it looks like is just a dense shadow behind the gallbladder wall. I'm going to let the video play now, and I'm going to pause and show you that we can identify this as the gallbladder because it's adjacent to the portal vein and the common bile duct. I'm going to let this video play. Be sure that you can identify that this is actually the gallbladder. It's just that it's so full of stones, all you're seeing is the wall, the echo of the stones, and the dense shadow behind them. Now I'm going to play that same video in short axis. You'll see we've rotated our probe, and now we're scanning from the fundus of the gallbladder down towards the portal triad. But again, we have that same appearance of wall, echo, shadow, but we're able to confirm it's the gallbladder because of its relationship to the portal triad. Let's look at this video now and look very closely. This is a long axis view of the gallbladder, and there is a stone here, but it's hiding. So let me pause the video here. Did you see it? There's the stone. It's in the neck of the gallbladder. And if you have an isolated stone impacted in the neck of the gallbladder, it can be a challenge to find unless you're looking very closely for that dense shadow deep to the stone. Here's another example of gallbladder sludge. Sometimes I have residents who will see artifact in the gallbladder, as you see some artifact here up towards the fundus of the gallbladder, and they'll wonder if that is sludge. You can see here though that sludge is going to be gravity dependent. It also is usually well defined, well demarcated, and almost has an appearance of a meniscus at the top of it. Let me show you now a couple examples of pericholecystic fluid. This is going to be black anechoic fluid that's going to surround the gallbladder. You see it here in a couple locations. It can also be a little more subtle. Look very closely at this video. I'm going to pause it here. Did you see it? There's a small wedge of fluid here. So a small anechoic fluid collection adjacent to the gallbladder concerning for pericholecystic fluid. Here's an example of a still shot of the gallbladder in long axis. You can see that they've measured the anterior wall thickness, and it's very thick. I believe it's almost 8 millimeters there. You can also see multiple large stones and their dense shadow behind them. Let's discuss now briefly choledocholithiasis. This condition is a stone impacted in the common bile duct that's going to cause dilatation of that duct. It's generally associated with abnormal LFTs, including an elevated bilirubin and transaminases. And you'll often have concomitant pancreatitis depending on the location of the stone. Now the stone is not often seen on ultrasound, so what we're looking for is dilatation of the duct proximal to that stone. Here's an example of the common bile duct in long axis, just superficial to the portal vein. We've used power Doppler in this image to confirm flow in the portal vein and absence of flow in the common bile duct. Then we've measured it, and this is a little large at 9 millimeters. What are some other findings that we might see in the gallbladder when we're performing an ultrasound? Well, you might have a lot of comet tails coming from the wall, and that could be one of two things. If the patient is sick and has a lot of pain in that area, then it may be a gas-forming organism causing emphysematous cholecystitis. However, if the patient is not sick or not complaining of pain, it may be a benign condition called adenomyomatosis, wherein they have hypercholesterolosis of the gallbladder wall. Here's an example of that hypercholesterolosis or that adenomyomatosis, and you see here that the anterior wall has a lot of comet tail artifacts extending down from it. Gallbladder polyps are another thing you might see in the gallbladder. Now these will be adherent to the wall, so they should not be mobile or gravity dependent. They rarely cause complication unless they begin to obstruct the outflow of the gallbladder, and they have a very low risk for malignancy unless they're large. Look closely at this video. You'll see two echogenic structures adherent to the gallbladder wall, but they lack any associated shadow, and because they're adherent to the wall, these are gallbladder polyps. Gallbladder wall folds are another very common finding, and these are benign and often congenital and are very frequently seen when performing this study. So a few errors you might make as you're learning this. The most common mistake would be to misidentify the gallbladder, and structures that could mimic the gallbladder would be the duodenum, a renal cyst, or vasculature such as the IVC or the aorta. So you'll want to look closely to confirm the gallbladder and its association with the Portal Triad. You also may be unable to identify the gallbladder if it's full of stones, so we talked about the West sign, if it's very small and contracted, such as following a meal, or of course if it's surgically absent. Recall that if the patient has had a cholecystectomy, the common bile duct will often dilate physiologically in response to that. So in summary, this is the technique that I use to perform the gallbladder ultrasound. Once I identify the gallbladder in the right upper quadrant, I'm going to sweep through it in the long axis looking for stones, confirming its association with the Portal Triad, and looking for any inflammatory changes such as thickening of the wall or pericholecystic fluid. I'm then going to turn the probe into short axis and examine the gallbladder from the fundus down through the neck, again looking for the same things, paying particular attention in both of these views to the neck of the gallbladder to make sure I don't miss an impacted stone. I'm then going to freeze the image perpendicular to the wall so that I can measure the anterior wall thickness. And lastly, I'm going to again identify the Portal Triad, use color flow to identify the common bile duct, which will have an absence of flow, and then freeze the image and measure the common bile duct. So in summary, remember to identify not only the gallbladder but the Portal Triad, carefully look for stones and pericholecystic fluid as you scan through the gallbladder. Don't forget to ask the patient if this location, as you press over the gallbladder, is their maximal location of pain, as the sonographic Murphy sign is the most sensitive finding in cholecystitis. And then remember your two normal values, the anterior wall thickness being less than 3 to 4 millimeters, and the common bile duct either being less than 6 millimeters or less than 4 millimeters plus 1 millimeter for each decade of life over age 40. Thank you for your attention to this lecture. I do hope it was educational. As always, please feel free to contact me with any questions or concerns, and please continue to visit our website in the future for more lectures and educational material.